Hello everyone. This is another video focusing in on the patient who requires mechanical ventilation. I've been asked by the house staff to talk a little bit more about patients who are on the ventilator. How do we as critical care practitioners approach patients in general who are on the ventilator? How do we think about weaning them off the ventilator? And what are some of the approaches that we use when we're analyzing arterial blood gases? Again, this particular video is for a house officer on their first rotation in the intensive care unit. A patient who's intubated really is usually intubated for two reasons, and that the focus when you're managing them is in two areas. Is it problems with oxygenation, or is it problems with ventilation? If there's problems with oxygenation, your focus is going to be to manipulate two primary variables. The FiO2, the fraction of inspired oxygen, which goes from 100% down to room air, 21%, and the PEEP, positive end expiratory pressure. It's important that you remember that, at least in our intensive care unit, that most patients should be on some form of physiologic PEEP, 5 centimeters of water. Other patients have problems with hypercapnia, and this is very common in the intensive care unit. For example, patients with chronic obstructive pulmonary disease can have hypercapnia. Patients who have severe sepsis also can have issues with hypercapnia because of increased CO2 production, as well as increased dead space in patients who have ARDS and septic shock. In those patients, you're thinking about minute ventilation, and you're thinking about tidal volume, and you're thinking about respiratory rate. And again, remembering that minute ventilation is respiratory rate times tidal volume if somebody is hypercapnic. The focus from the perspective of a house officer coming up to a new patient that they're meeting for the first time in the ICU is to look at the FiO2 and PEEP. Look to see if the patient meets criteria for the acute respiratory distress syndrome. And again, we've talked about this. The correct clinical scenario, bilateral infiltrates, usually asymmetric, and a PF ratio where we talk about it 300 to 200, 200 to 100, and less than 100 being mild, moderate, and severe. One of the important things when I'm working with house officers in terms of arterial blood gases is to not pick any one part of the arterial blood gas out and just report or analyze that. You really need to look at the entire pH, PCO2, PO2, serum bicarb, SAT, and lactate, usually with a set of electrolytes, before you can more fully analyze it. Again, keeping in mind that common things in the intensive care unit are primary metabolic acidosis, and you can use the Winter's formula to determine if there's appropriate compensation. Patients that may come into the intensive care unit with a chronic respiratory acidosis and may have an acute on chronic respiratory acidosis. In addition, as we discussed numerous times, both in lectures as well as on the videos, is patients who are surgical patients often have significant issues with NG tube suctioning. And again, if you're removing acid, you can develop a metabolic alkalosis. And this can be very difficult because if a patient has COPD and has a chronic respiratory acidosis with metabolic compensation, and then you've been doing NG tube suctioning for a while, leading to a worsening metabolic alkalosis, this can exacerbate the underlying clinical situation where it's no longer compensated appropriately. In terms of basics of the ventilator settings, I guess I would share with you that whatever unit you're in, there will be some form of assist control. And again, as we've discussed before, when you first see a patient in the ICU, or if you first receive a patient from the operative theater, you should have the patient initially on 100% oxygen and wean the oxygen down rapidly, working with the nurses and the respiratory therapists, keeping the oxygen saturation above 95%. You should get an initial arterial blood gas when the patient comes into the intensive care unit, making sure that the patient has received appropriate oxygenation and ventilation while they've been in the operating room. This is a very, very important point that I can't emphasize enough. You should set an initial respiratory rate of around 12 to 15, but you may need to go higher. Tidal volumes should be around 6 to 8 mLs per kilo predicted body weight, and in general, you're in the 400 milliliter range, but I would strongly recommend downloading one of the apps where you can calculate the actual predicted tidal volume based on the ideal body weight. And then again, most patients should be starting out on a PEEP level of around 5. When you first get the patient or you're managing the patient overnight, your focus is to optimize the arterial blood gas. And many residents ask me this, and the focus is look at the pH. Don't stay focused on all the other issues. Many times, especially if they've required emergent surgery, the patients will have a severe metabolic acidosis, and this will require a higher minute ventilation to optimize the pH. And so you'll often see that when they first come out of the operating room, they will have both a metabolic and respiratory acidosis. Your job there is to see what component, if any, can be corrected by giving sodium bicarbonate, and what else can be done, including increasing the respiratory rate. Also remember that patients may have been paralyzed and not reversed when they come into the intensive care unit, and so the patient will not be breathing above the ventilator. Some of the more sophisticated issues are different weaning modes, and again, I can't emphasize enough how important this concept of a daily sedation vacation and a daily spontaneous breathing trial is to modern critical care. And again, it's an important part of the care in our unit. It's called the ABCDE bundle. And our focus here is that every patient, every day, gets an assessment for decreasing their level of sedation and combining that with a daily spontaneous breathing trial. Which particular spontaneous breathing trial doesn't matter as much as that you do an assessment of one. And again, our focus here would be whether it's low levels of pressure support or a formal CPAP trial or a T-tube trial. This reminds me to talk for just a couple of minutes about the concept of pressure support, and we spoke about it in our other video, but I'll mention it again. This is a weaning mode. It's a mode where you set an FiO2 and you set a PEEP, but you don't set a respiratory rate and you don't set a tidal volume. You set a pressure support level. The idea is, since you don't set a rate, the patient has to be awake enough and driving their own respiratory rate, and the tidal volumes that they will get depend on their effort. So a patient who's taking good effort will be very comfortable on a pressure support level of 10 over a PEEP of 5. And again, this kind of an approach is a very reasonable one, although from a purely academic standpoint, the pressure support levels really should be quite low to allow the patient to really demonstrate their effort. So in conclusion, for this particular video, we've tried to share with you some of our approaches from a very basic standpoint of a patient who gets admitted and is on the ventilator. Your focus when they first come in should be, I need a baseline arterial blood gas to make sure this patient doesn't have severe hypoxemia or severe metabolic acidosis or hyperlactatemia. I need to follow that up quickly and optimize the ABG to the extent that it's possible. If the patient has a component of respiratory hypercapnia, then I should use the Winters formula to find out how I can optimize their metabolic component. And if you feel that there's a severe metabolic component and that requires the patient to receive sodium bicarbonate intravenously, you should do that as well, remembering that the patient may be paralyzed still from the surgery. We've talked a little bit about the different weaning modes and the all-important concept of a spontaneous breathing trial. We don't want to focus on this particular video on the more sophisticated weaning modes such as APRV, because they can be a bit of a distraction for a new house officer when your focus is the basics of what am I looking at on the ventilator and how am I deciding how the patient is doing. And again, the last thing to remember is that during the spontaneous breathing trial, you're looking at specific criteria. Is the patient hypoxic, tachypnic, tachycardic, anxious, or agitated, or none of those things? It's very important to remember that the patient needs to look comfortable in a global setting for the patient to be able to meet criteria for extubation. And it's very important, in addition, that every member of the multidisciplinary team is on the same page about what's being done in the morning during the spontaneous breathing trial. Thank you so much.